video, last time we had discussed about all the diagnostic methods. In this video, we will do a detailed discussion of all the diseases of the dental pulp. One of the very famous quotations that we all come across when we are going through this chapter is, some pulps will die if you look crossly at them, while others can't be killed even with an axe. The value of pulp as an integral part of tooth, both anatomically and functionally, should be recognized, and every effort should be made to conserve it till the last. So, accurate pulpal diagnosis is the key to all endodontic treatment. Moving to causes of pulp disease, we will come across in the clinic a variety of diseases of the pulp. So, what are the reason why those are caused? So categorically they are different causes of pulps are enlisted. So we will start with the physical causes. Under physical causes, first are the mechanical injuries, in which the number one is the trauma. When a trauma happens, it may or may not result in the fracture of the root of the crown. Most commonly seen in children, mostly because they are into a lot of sports, and while they are learning to walk, there will be a lot of fall, and the front upper teeth are the one that are mostly traumatized. Also during fight or accident or some habits such as opening of bobby pin or beer bottle with the teeth, we can see the trauma is occurring for the dental pulp. Next are the pathologic wear. Here complete or partial pulpal exposure occurs due to either attrition, abrasion or compulsive drugs. If secondary dentine is not deposited rapidly enough, occlusal trauma may also injure pulp because of repeated irritation to the neurovascular bundle in the periradicular area. Some of the iatrogenic causes of dental injuries include accidental exposure when we are doing an excavation of a very deep carious tooth structure. Okay. Second is during orthodontic treatment, if there is too rapid movement of the teeth. Also, if using pins for mechanical retention and by chance the drilling takes place very close to the pulp. Also, we have to remember that remaining dentin thickness of 1.1 to 1.5 mm is a minimum desirable amount of thickness to protect the pulp against inflammation and bacteria in the long run after the filling has been done. Here, a clinical note to remember is always we have to use a small cotton pellet to dry cavity after excavation, because if we are using a three-way syringe to rapidly blast air into it, it will cause aspiration of the odontoblastic nuclei. Moving on to the next, that is cracked tooth syndrome. In cracked tooth syndrome, what generally happens is there is incomplete fracture through the body of the tooth, and it may cause pain of apparently idiopathic origin. Patient usually complains of mild to excruciating pain at the initiation or during the release of the biting pressure. One of the particular diagnosis is that when the patient is asked to bite on a cotton roll, on relieving the biting pressure, the patient says that the pain is experienced. Close examination can also reveal the cracked enamel, and for better visualization, dye or trans-illumination can be used to see the crack line. So, treatment-wise, for both the cases where there is a crack line running deep into the enamel or where there is a necrotic pulp due to years of irritation, the complete endodontic treatment followed by a full coverage restoration has to be done, where we can immobilize the fragment and it will be a successful line of treatment. Moving on to the next, parodontalgia. It is also synonymously called as the aerodontalgia. Here, toothache is experienced at low atmospheric pressure, either when the person is on a flight or during a test run in a decompression chamber. So, next, moving on to thermal injuries. It occurs from the heat during cavity preparation in absence of coolant. The stream of water or air water spray must be directed at the dentine directly under the burr for maximum cooling. So it has to be seen that the handpiece is not defective, that the jet of water is actually a bit far angulated from the burr where the cutting is occurring. Next, heat conduction by fillings. Now, recently it is not experienced so much. It was more commonly seen when there was a deep amalgam filling done without a base. Also, frictional heat during polishing. So, this kind of pulp injury is generally transient in nature, and the pulp tends to come back to its normal Chemical injury in that amalgam or composite filling with very less remaining dentin thickness may produce some amount of sensitivity. So here an important clinical note will be that always use a base or a sub base when it is clinically indicated. Otherwise, say for example, it was a very deep cavity and just because of the direct filling being placed, the patient is experiencing that intense sensitivity, and we interpret it as to be a tooth that will need a root canal treatment, and we will just go ahead with the root canal treatment. Whereas from the clinician's point of view, if we had used a proper base over there, the pulp was protected enough, and then the filling was placed, then the tooth would not have gone into. Coming to bacteria, in 1894 W.D. Miller had suggested that it is a possible cause of pulp inflammation. Since then, and even today, it is one of the most common causes of all the pulp inflammation that we come across. Not only the entire bacteria, even by the presence of merely its byproducts also, it is enough to cause the inflammation. Coming to reversible pulpitis. It is mild to moderate inflammatory condition which is caused by a noxious stimuli which returns to normal state on removal of the stimulus. Causes can be trauma, very low remaining dentin thickness, chemical, etc. The symptoms are sharp momentary pain. Diagnosis is by the history, the symptoms, and clinical tests. Here, the treatment is removal of the noxious stimuli, which will generally make the patient feel comfortable again. A very important point to note over here clinically is that this point too, that once the symptom have subsided, the tooth should be tested for vitality to make sure that the pulpal necrosis had not occurred. And say for example, the patient was not feeling any more pain, and later we down the line we get to know that actually there was a pulpal necrosis and it was non-vital all the way. So this the second step is very important. Third is when the pain persists despite the proper treatment, the pulpal inflammation should be regarded as irreversible, and then pulp should be extirpated. And then once it is completed, prognosis is quite favorable. Now, irreversible pulpitis. It's a persistent inflammatory condition of the pulp. It may be symptomatic or asymptomatic in nature, caused by a noxious stimuli. The pain persists for several minutes to hours, lingering even after removal of the stimuli, unlike the reversible, where after removal, the patient says they are comfortable. Causes of irreversible pulpitis, most common is bacteria. Along with that, all the causes that we discussed so far. Long-standing reversible pulpitis, when kept untreated for a very long time, can deteriorate into irreversible. So it's an important part to remember. Symptoms are paroxysm of pain due to sudden temperature change during eating sweet or sour, and due to pressure from food impaction into the cavity space that was created. Nature of pain, it is sharp, piercing or shooting in type and generally severe. It may be intermittent or continuous. One of the important histories to note down is the patient will say that while bending over or while lying down, there is exacerbation of pain, possibly due to fluctuation in the intrapulpal pressure. In later stages, the pain is more severe and is generally described as boring, gnawing, or throbbing, as if the tooth is under constant pressure. Here, diagnosis is done using the history, inspection, and radio. Treatment consists of complete removal of pulp or surgical removal of the tooth if the remaining tooth structure is not restorable. Coming to chronic hyperplastic pulpitis, it is also called as pulp polyp, characterized by development of granulation tissue covered at times with epithelium due to long-standing low-grade irritation. Cause is slow, progressive, carious exposure of the pulp. Symptoms, it is basically symptomless except when during mastication the pressure from food bolus may cause discomfort to the mass of the pulp that is exposed. Mostly seen in children and young adults. We have to do a clear differential diagnosis and not mix it up with proliferative gingival tissue, which may appear to be quite similar. Treatment of pulp polyp is the entire pulp mass needs to be extirpated and routine endo has to be followed. Coming on to internal resorption. It is an idiopathic, slow or fast progressive resorptive process occurring in the dentin of the pulp chamber or root canal of the tooth. The cause generally it is unknown. Sometimes history of trauma can be traced back to that particular tooth. The crown portion, when the inner part is thinned out, the thin enamel appears as pink spot. So it is also synonymous with this terminology. Differential diagnosis, we have to clearly make sure that it is not an external resorption and it's an internal one. Treatment involves extirpation of the pulp, which stops the resorptive process, then routine endo. But obturation needs special effort because of the defect that is caused inside the canal. So, in such a scenario, a simple obturation won't help. We have to use preferably a thermoplasticized gutta percha method to seal the defect as well. Also, if the internal resorption process is much more destructive in nature and has caused any kind of perforation, first that perforation has to be repaired using MTA or biodentin and then followed by routine obturation. Coming to pulp degeneration, it can be calcific degeneration. Here, part of pulp tissue is replaced by calcific material, which is stones or denticles. It may be present mostly in the pulp chamber but also in the canals. They may be loose or attached. Currently, it is seen that a great number of adults are having pulp stones present during the process of endodontics. It is encountered. Atrophic degeneration, pulp tissue gets less sensitive, more commonly seen in older people. Necrosis of pulp. It is basically death of pulp. It may be partial or total. Mostly it is a sequel to inflammation or also can be a history of trauma. Types are coagulative and liquefaction. The end products of pulp decomposition, such as the hydrogen sulfide, ammonia, fatty substances, etc., contribute to the unpleasant odor, sometimes emanating during access opening. Symptoms generally asymptomatic. Frequently, the discoloration on the tooth due to seepage of the necrotic fluid into the dental tubules is the first indication that the pulp is dead. We have to keep in mind important note, if there is a partial necrosis probably in a multi-rooted tooth, sometimes it will respond to thermal changes. It is actually a kind of a false positive risk. Diagnosis, the radiograph will show generally a large cavity that is present. Also, there will be periapical changes evident. Generally, there is no response to any kind of cold EPT or test cavity of that particular tooth. Treatment is access opening and preparation. Inter-appointment dressing has to be given. And lastly, obturation. Prognosis is favored. That's all for today. We will wrap up this session of lecture. See you again in the next.